Hello guys, today we are starting with topographic anatomy and operative surgery. We're beginning with the very basics, the definition of terms. Our textbook for this course is going to be Topographic Anatomy and Operative Surgery textbook by Anatoly V. Nikolaev. It's a Russian textbook. Beginning with the very basics. Topos means a place. Graphos means to write or describe. Therefore, topography is the description of a place, and topographic anatomy is the science that studies the spatial interposition of all organs and tissues of the body in different systems and various regions of the body. And topographic anatomy is also known as regional anatomy. So study different regions, for example, studying the thoracic region or the abdominal region, looking at different structures. Topographic anatomy is based on systemic anatomy. Topographic anatomy is also known as regional anatomy, as I mentioned, and it is based on systemic anatomy. And systemic anatomy studies different organ systems, right? Which is general anatomy in essence. So systemic anatomy studies skeletal system, cardiovascular system, respiratory system, central nervous system, and the lymphatic system, and so on and so forth. The systemic and the topographic anatomies, they both serve as the basis for clinical anatomy, right? So the topographic anatomy and the systemic anatomy together, they are the basis for clinical anatomy. Clinical anatomy, on the other hand, deals with the human body structures, be it normal anatomy, the normal anatomy of body structures, as well as the pathological anatomy of body structures, according to the various needs of various fields of clinical medicine. So clinical, and then clinical and topographic anatomy. The clinical anatomy and topographic anatomy together, they form as the link between the basic sciences and clinical medicine. So topographic anatomy together with clinical anatomy, they form as the link between basic sciences and clinical medicine. Clinical anatomy, as well as together with topographic anatomy, as we said, they're the foundation. Whereas on the other hand, clinical medicine deals with diagnosis of diseases, describing of diseases, allows us to diagnose the diseases, allows us to describe the treatment of a disease. That's why when we are discussing clinical anatomy as well as topographic anatomy, we use a lot of clinical terminologies, because essentially the topographic and clinical anatomy helps us in our execution of clinical medicine. Surgical anatomy. Surgical anatomy is a part of clinical anatomy as well as topographic anatomy. And the aim of surgical anatomy is to describe the position of an organ in general as a subject for surgical operation, even if it is situated in several regions. All right, for example, an oncologist would have to know topographic anatomy of the esophagus, as you have the gastrointestinal tract right here. We have a GIT here. So for an oncologist, the topographic anatomy of the esophagus will be of special interest. And this would allow the oncologist to determine where the tumor is, where the cancer is located along the length of the esophagus. And of course, as we know, the esophagus is divided into the cervical part, which is in the neck, is divided into the, you have the cervical part, and then you have the pectoral part, and then you have the abdominal parts, right? For the plastic surgeon, they also need to know topographic anatomy, because for them to be able to resect, sometimes you have certain tumors of the stomach or tumors of the pancreas, and therefore that will necessitate the surgeon to resect the stomach, gastrectomia, to perform gastrectomia. And then the anastomosis of the proximal part of the, as well, esophagus. So the plastic surgeon needs to know the anatomy very well, so that the surgical anatomy, so that he can be able to connect the two, to carry out the operation well, to resect the organs that need to be resected, as well as to anastomose the organs that need to be anastomosed. The surgeon must also have a thorough knowledge of connections between regions along blood vessels. So the surgeon needs to know what are the different anastomosis, the natural anastomosis of blood vessels. What are the different cellular spaces, and the interstices, to be able to understand the progression of pathological processes, the spread, especially when you have suppurative or pio-inflammatory processes that are happening in a particular cavity. For example, when you have the abdominal cavity, there is a certain movement of fluids along the abdominal cavity. So the surgeon's understanding and clear knowledge of these processes will allow the surgeon to be able to diagnose correctly and also manage correctly the condition at hand. Also, knowledge of, for example, the lymphatic nervous system, knowledge of the lymphatic drainage system is very important for all doctors, particularly the oncologists, because the lymphatic drainage system serves as the pathway for metastasis of tumors, etc. But to have a very good and competent knowledge of topographic anatomy, as we said, is important for surgeons. It's important for all doctors in all specialties, and the surgeon must have the right knowledge of topographic anatomy in order to be able to diagnose correctly and identify the precise location of the pathological process. Medical doctors of all specialties should be able to visualize the source of the pathological process and the directions of the further spread of the pathological process. So every doctor must be able to locate every organ in its relation to other body parts. Must be able to locate where is the organ in relation to other body parts. For example, where is the heart in relation to the lungs? Where is the stomach in relation to the liver and the pancreas? Where is the esophagus in relation to the veins and the arteries and the heart and the bones? And so every doctor must be able to locate every organ in relation to the other body parts, the skeleton, as well as other organs. And the doctor should be able to determine the depth of the location of the organ and its relation to larger vessels, arteries and veins, and accompanying nerves. So the doctor must be able to see through his patients, as it were, without the use of an X-ray imaging machine. All right. So let us move on. As we said, a competent, a competent knowledge of topographic anatomy allows you as a doctor to analyze the presenting symptoms of your patient, to prove your diagnosis, and to plan the treatment more efficiently. All right. So now let's talk about regional anatomy. Regional anatomy is also topographic anatomy. Yeah. Topographic anatomy is also known as regional anatomy. Now, region is an area. This area is marked artificially on the surface of the body. For example, the abdominal area, we divide it into 9 parts, right? And you have the umbilicus right here. And regional anatomy allows us, for example, to identify where's the abdominal cavity, where's the pelvic cavity, what are the borders of the chest cavity, the thoracic cavity. And so the region of the body is an artificially marked area on the surface of the body, and within the limits of that area, you have the topography of deep anatomic structures. For example, you have different structures here. You have different regions within modern anatomic nomenclature, in which you can immediately see the side of the body that is being considered. The regions of the body are conventionally marked within the limits of certain body parts. So the region, so you have the body, the entire body, for example, as we have here in our caricature here. And then you have, for example, the regions, the region of the head, the region of the neck, the region of the trunk, the region of the lower limbs, the region of the upper limbs, right? And you have, for example, in the region of the upper limb, you have the axillary region, right? You have the scapular region, you have the deltoid region, you have the subclavian region, the region of the upper limbs. So within the limits of the region, so for example, the subclavian region that we just mentioned, all the included anatomic structures are described. So the anatomic structures, they have particular names, including structures that just transit through, like large arteries and veins. They receive special names as they pass through each particular region. For example, within the subclavian artery, for example, when we talk about the upper limb, within the shoulder girdle, for example, talking about the subclavian region, we have beneath the clavicle, right? So you have your clavicle here, and then you have the subclavian region, and then you have the supraclavicular region here. And so as the artery goes through the subclavian region, you have the subclavian artery. As the artery goes on to the axillary region, then it becomes known as the axillary artery, right? So that is the regional anatomy. Now, other very important terminologies that we use for topographic anatomy, as we said, in topographic anatomy, we are describing the location, the relationship between the organ and other organs, between the organs and other structures of the body. So in describing the anatomic structures, We are defining its position, right, in relation to the rest of the body. And we use certain terminologies. We have Holotapi, and then we are also going to look at Skeletopy. We also have surface landmarks, projections, as well as Synthopy. So these are the different terminologies that allow us to describe the topography of an organ. So let's begin with Holotapi. What is Holotapi? Holotapi describes the position of an organ in relationship to the rest of the body, as well as in relationship to the different parts of organs. In relationship to the region in which the organ is also located. In describing Holotapi, for example, we're looking at the position of the organ. For example, we have our heart here, right? You have the right atrium here, right ventricle, left atrium here, right? And then you have the aorta here, and then you have the great artery here, the pulmonary artery here. So in describing the Holotapi, for example, of the heart, we are looking at what is the relationship of the heart in the median sagittal plane, right? Describing the relationship of the organ, the relationship, for example, of the heart to the median sagittal plane, which means, is the heart located in the left side of the thoracic cavity or the right side of the thoracic cavity? The stomach, is it located in the left side of the abdominal cavity or in the right side of the abdominal cavity? That is the medial. So that is the relationship along the median sagittal plane. And then you have the relationship along the horizontal plane. So, which means, is the organ lying in the upper part of the body cavity or in the lower part of the body cavity, right? A patient presents with pain in the abdomen. Is it the upper quadrant or is it the lower quadrant, right? So is the upper part of the cavity or is the lower part of the cavity? Frontal plane. The relationship of the organ, right? The position of the organ in relation to the frontal plane. So that is also part of the Holotapi. Frontal plane, the relationship of the organ along the frontal plane tells us whether the organ is near to the anterior surface of the body or to the posterior surface of the body. For example, you have, if I draw this well, you have the chest cavity there, and then you have the diaphragm here, and then you have the abdominal cavity. You have your great vessel here, right? Is it anteriorly located or is it posteriorly located, right? So that is the relationship along the frontal plane. So of course, the aorta is posteriorly located along the frontal plane. Moreover, an organ can be described under Holotapi either to be proximal or distal. For example, here we have our humerus, and the humerus, we can describe the distal part of the humerus or the proximal part of the humerus, right? Also, the Skeletopy. Then we move on to Skeletopy. What is Skeletopy? Skeletopy is the location or the projection of an organ in relationship to the nearest bones, right? So how what are the nearest bones close to that region? In other words, we are looking at, we're looking at the margins, the limits of the organ. What are the structures that form, what are the bones that form the borders of that organ? In our drawing here, for example, we have the lung. We have our lung here, and we are looking at what is the upper margin? What is the upper margin? What is the upper region, upper limit? Or what is the lower margin? What is the lower margin of the lung? What is the lower limit? And so Skeletopy helps us to describe that. And we can say, for example, the apex of the lung, which is the upper margin, which is demarcated by the upper margin, which is the 1 to 2 centimeters above the clavicle, for example. We can say the lower margin of the lung, when upon expiration, it's in the 6th intercostal space, right? Which is right here. Or we can say the lower margin of the lung upon inhalation is the 6th intercostal, 10th intercostal space is the 10th intercostal space. The lower margin of the lung upon inhalation is the 10th intercostal space, for example. Moreover, we can say the margins of the liver in relation to the ribs and the input. We can talk about the margins of the liver in relation to the ribs and the intercostal spaces. Or we can talk about the position and the margins of the pancreas in relation to the lumbar vessels. Now, let's go to surface markings. Surface markings, they are the locations. They describe for us the locations of anatomical structures in relation to or marked on the skin determined by palpation. So in surface landmarks, we're looking at the location of the organ when we palpate. All right, so it allows us to explore deeper lying organs like the kidney, aorta, for example, when you have when the patient has aortic aneurysm, when the patient has valvular heart diseases, and we want to find out which valve is affected. So we can use surface land markings. Also, as we can see here in our drawing, surface landmarks are widely applied to determine the limits between the regions, as well as for constructing projections of the deeper anatomic structures. So they help us to demarcate, to be able to understand where are the deeper anatomical structures located. For example, the neurovascular fascicles. Neurovascular fascicles, the neurons and the vessels, the nerves and the blood vessels that normally travel together. Where are they? How can we understand their pathway? By palpating. So when we palpate, we use the landmarks to then identify and say, aha, here is the subclavian artery. Here is the axillary artery, for example. Right. So surface landmarks include bony prominences that can be palpated irrespective of the amount of subcutaneous fat, subcutaneous adipose tissue, or irrespective of skin folds, as well as irrespective of recesses or eminences on the surfaces of the body. And so the bony prominences that allows us to mark surface landmarks, allows us to identify surface landmarks. They include, for example, the clavicle. Yep. For example, the clavicle here. We have, for example, the humeral epicondyle, for example, here. Humeral epicondyle. or the anterosuperior spina iliaca, right? So you have the superior spina iliaca. Anterosuperiorly, you have a prominence there on either side of the waist. Okay, so the clavicle, for example, can be used as a surface landmark for inserting the central venous catheter, which is inserted in the middle third, right? So you divide the clavicle into 3 parts. The middle third, right? So, moreover, tendons of some muscles can be palpated, especially when the muscles are contracted, right? And the muscles, and so the tendons are used as surface landmarks. For example, the Achilles tendon. Achilles tendon can be used as a surface landmark. The tendons of the muscles of the inside of the arm, yeah. Tendons, for example, the tendons of the musculus biceps brachii or triceps brachii. The tendons that run through the wrist, yeah, they can also be used as surface landmarkings. So the tendons of, for example, musculus, the tendon of musculus biceps brachii, this one can be used, can help us to identify where to place the cuff for measuring blood pressure. So you have the tendon there, and then you have the muscle. You see sometimes this muscle, the one that protrudes here. Also you have the tendon there. So the tendon gives you the location for it to place your blood pressure cuff. On the distal transverse palmar fold, right? So you have, this is your palm, right? So this is proximal. And this is your distal part, right? So again, this is distal of the palm, and this is proximal of the palm. So in the distal proximal part of the palm, distally along the arm, you can use this distal part to mark as a surface landmark, as a projection of the metacarpophalangeal articulations, right? So as you can see, the green circle, that is your phalanges, your metacarpal bones. So your metacarpal bones are in that region, and then you have your phalangeal bones in that region. And so, and in that region, in the metacarpophalangeal articulate, in that region, so where these two regions meet, you have your metacarpophalangeal articulations, right, within the distal part of the palm. And so there in that region, you'll find the blind sacs. The blind sacs. Blind sac of the synovial sheaths of the flexors of the index finger, as well as the synovial sheaths of the flexors of the middle finger, as well as is marked by the blue arrows, as well as the synovial sheaths of the ring fingers, the ring finger. So within the distal part of the palm, at the junction between the metacarpals and the carpal bones, so in other words, the metacarpophalangeal articulation, In that region, you find the blind sacs of the synovial sheaths of the flexors of the index finger, the middle finger, and the ring finger. And so for the surgeon to know exactly where these tendons are, the surgeon will be able to correctly make the right surgical incision when there is an inflammatory process, either caused by an infection, right? When you have a purulent or suppurative inflammatory process of the synovial sheath, also known as tendovaginitis. Yep, tendovaginitis. So within that region, right there, that's where you find the blind sacs of the synovial sheaths of the flexors of the three fingers. And so there you'll be able, the surgeon will be able to make the right surgical incision to treat tendovaginitis. So the middle of the clavicle, as I mentioned earlier, right there, is then used as a landmark for puncturing the subclavian vein when inserting the central venous catheter. And we know that the central venous catheter is used for infusing fluids for fast infusion of fluids, of large amounts of fluids, as well as for administration of medication, especially for patients in the ICU. Surface landmarks, they are very important, crucial for studying the anatomy, the topographic anatomy of regions and organs. Surface landmarks, they allow us to determine the limits of various anatomical regions. For example, the limits of the abdominal cavity, the limits of the thoracic cavity, as well as the limits that correspond to the contours of a visceral organ as projected on the surface of the body. Right, very, very important. Now, projections. Projections are very important. The projection of an anatomic subject to the surface of the body is also very, very important. A projection is a contour. Projection is a contour. What type of contour? The contour of an organ. For example, here you have your kidney, right? Or a contour of the part of an organ. Like here we have the adrenal organs, of course, also the contours of the organs on the surface of the body connected with a system of surface landmarks. So, for example, you can say the kidney is projected along the upper pole of the kidneys are projected along the 12th rib. And the position of any linear. So when you have any linear structure, the linear anatomical structure, for example, the inguinal ligament. For example, the inguinal ligament. When you have any linear anatomical structure, we describe the surface anatomy, the surface of the body with the surface of that anatomy, of that anatomical structure, with the help of the surface landmarks. Again, when the position of any linear anatomical structure is described on the surface of the body, when we're describing the anatomical structure that is linear on the surface of the body, we use surface landmarks such as a projective line. So the position of a neurovascular bundle or a bundle. In other words, I'm saying that we use a linear, when you have a linear object, like a ligament, we use a linear, when you have a linear object, we use a projectile line. We use a projectile line to describe the movement or the length of that object, of that anatomical structure. And this projectile line usually corresponds to the direction of the anatomical object. We have here the ligament of the inguinal canal, inguinal ligament. And by help of the projectile of the projective line, by the help of the projective line, we are able to connect the spina iliaca at point 1 here and the pubic tubercle at point 2. And then the projective line allows us to see the projection of the inguinal ligament. Synthopy. Synthopy allows us to describe the position of an organ in relation to the adjoining anatomic structures. The position of an organ in relation to the adjoining anatomical structures. For example, the relationship of an organ to other organs, the relationship of an organ to muscles, the relationship of the organ to vessels and nerves. So, in synthopy, we are looking at the different layers. So the synthopy is described by examining the layer by layer study of an anatomical region from surface into the depth. In other words, synthopy is the location of the organ. In other words, synthopy is the location of the organ in relation to the different layers of the body, from the skin to the deeper layer of the body. So the layer by layer study of the body is one of the main approaches in studying topographical anatomy, toponatomy in other words. And in every anatomical region, the layer beneath the skin, so we always start with the skin. We always start with the skin. We always start with the skin. And so the first layer is always the skin. And then after that, we always have the subcutaneous tissue, right? Then we always have the subcutaneous tissue following the skin. And then after that, you have the superficial fascia superficialis. Then after that, you have the proper fascia, in other words, fascia proper. And then that is followed by the deep superficial structures, which can be organs and so forth. So you have the skin, subcutaneous adipose tissue, and then the superficial fascia, and then the facial proper, and then the deep superficial, then the deep subfascial structures, meaning the deep structures that are beneath the fascia proper. So we pay very careful attention to all these terminologies. They help us to navigate ourselves in describing topographical anatomy. So guys, I hope this was very important and helpful for, I'm sure this is very important. This is definitely very important. I hope it was helpful for all of you. Once again, we talked about topographic anatomy, which is also known as regional anatomy. And we talked about its relationship to systemic anatomy as well as clinical anatomy. And we talked about the different terminologies that are used to help us understand the topography of organs. We talked about holotopy, skeletopy, surface landmarks, projections, as well as the synthopy. Holotopy, we said, talks about the relationship of the organ to the rest of the body with respect to the different planes of the body. Skeletopy, the relationship of the organ to the nearby bones. Surface landmarks talks about when we palpate an organ, where do we find it on the surface? When we palpate on the skin, where do you locate that organ? So the relationship of the organ to the skin is determined by palpation. And then we said projections. These are bony prominences that protrude along with in relation to the surface landmarks, which help us to identify the location of different organs. So And then we talked about Synthopy, and Synthopy allows us, of course, we talked about projections, yes, projections, the bony prominences, then Synthopy, the position of the organ in relation to the adjoining anatomical structures, especially when we talk about other organs, muscle, vessels, nerves, especially talking about the relationship of the organ to the layer by layer structure, in relationship to the different layers of the body. Holotapi, relationship of the organ to the rest of the body. Skeletal, relationship of the organ, the position of the organ in relation to the bones. Surface landmarks, where is the organ when on the skin when we palpate. And projections, what are the bony prominences that tell us the bony prominences as well as tendons that tell us the location of certain structures. Synthopy, what is the relationship? What is the position of an organ in relationship to the different layers of the body as well as other anatomical structures? Thank you so much. Please like and subscribe and share this lesson with your friends and colleagues. And come back again for the next lesson as we continue describing and studying topographical anatomy and surgery and operative surgery together. I am Dr. Julius Kwedhi, MPH and PBMS and MD. Thank you so much.